Um, Welcome everybody to our first SAASM webinar of 2025. I'm David Walsh. I'm the Clinical Director of SAASM. And tonight we're going to have a hypothetical based on the logistics of transfer, but specifically in the rural setting. I'm only going to do three brief things. The next slide. The first is I'd like to do an acknowledgement to country, and the College of Surgeons acknowledges the Aboriginal and Torres Strait Islander people as traditional owners on the land that we meet today, and we extend our respect to elders past, present and emerging. The second thing I want to do is to thank all the members of our hypothetical panel, particularly our moderator, Guy Maddern, just in case I forget to do so later. And thirdly, I want to just explain why we think transfers are an important issue. And basically, if we look at one of the parameters that we can measure within ANZASM and SAASM, we can look at the number of clinical management issues, the ratio of management issues to cases. Thanks, Sam. And one of the key pieces of data that has emerged in the last 12 months or so is that when we look at the rate of clinical management issues in patients that are transferred compared to those that are not, overall in ANZASM there is an increase for transferred patients, but in South Australia, where our health system is very dependent on transfers because of our population, the risk of a clinical management issue is about 2 to 3-fold. So that's essentially the background to what we're going to talk about tonight. And I'd now like to hand the evening over to our moderator, Professor Guy Maddern. Guy, the floor is yours.
Thank you very much, David, and thank you for putting this all together. Now, a couple of things I'd just like to let individuals know is that, first of all, you will be able to type in questions, and then we will sort of synthesize those, and David will represent your views if you have a question. We're not going to be able to do hands up because that will, I think, be too chaotic. So please don't hesitate to ask questions if you feel, or disagree, make comments if you feel that we've not dealt with the matter appropriately. So that is quite important. Secondly, I want to just introduce the panel we have tonight. And some of them, well, sorry, before I do, I should just add that although this is South Australian Audit of Surgical Mortality webinar, we have sign-in from really every state in Australia, which is fantastic. And a number of our general practitioners who work in rural areas have also joined us tonight because, of course, they are often faced with trying to sort these sorts of issues out as well. So we have a sort of a fairly broad and eclectic audience. To help us discuss these topics, which most of us have had to face at some stage, I'm delighted to say that we've got Quentin Ralph, who's a general surgeon based in Port Lincoln, and he's been there for well over 20 years now, providing a very broad-based service to a fairly remote rural centre with adequate but not comprehensive facilities. And Quentin's going to really be trying to explain how a remote surgeon views patients, the transfers, and will highlight some of the problems. On the flip side, we have Darren Tonkin, who's a colorectal surgeon based at the Queen Elizabeth Hospital and in private practice in South Australia. He's head of colorectal surgery at the Queen Elizabeth Hospital, and he's the guy who has to take the phone calls and work out what the decision should be about bringing the patient or not bringing the patient, and so on. And Darren will try and we'll try and interrogate Darren a little bit on what his thought processes are when these issues come up. We have Mary White, who is chair of the South Australian branch of the Medical Board, but more importantly for tonight's discussions is an intensivist based at the Royal Adelaide, who is often needing to get involved with these transfers. And we want to really just discuss whether she's getting involved soon enough, whether she can provide more, and what are the problems that she finds she lands with that maybe could have been mitigated with a better approach. We also have Andrew Pearce, who is an emergency physician and currently the Director of Clinical Services at MedSTAR Retrieval Service. And MedSTAR, for those of you not in South Australia, is the system that provides the ability to bring out intensivists and anaesthetic support to then bring very ill patients through to the metropolitan centres. So Andrew's background and experience in that type of more urgent and more dramatic transfer is going to be very useful. And last but by no means least, we have Simon Jenkins, who's a consultant anaesthesist working at the Lyle McEwen Hospital. He's had experience in the MedSTAR type role in the past, and he's currently chair of the South Australian Anaesthetic Mortality Committee. So he is the person we're going to turn to give us a bit of guidance on how anaesthetic services can interact with the rural setting and what they need to know to optimise a transfer. So with that very brief introduction to what is really an outstanding panel, and thank you all of you for being available tonight, I would like to just develop an unfolding scenario. If we could have the first slide up, please. This is a picture that is known to us all. It's Australia. It's a gigantic country. And what we have there is the major metropolitan centres around the coast, as we all know. And we have enormous distances to bring our patients from 500, 600, 700 kilometres away, not infrequently, and even thousands of kilometres away on occasions. And this is a huge challenge. And while our metropolitan areas are extraordinarily well equipped and served, our rural areas are very variable. And certainly in South Australia, if I could have the next slide, please. In South Australia, we have a very substantial distances, actually. The South Australia is, in fact, an enormous state. It's perhaps not as big as Western Australia, but it's certainly extremely large. And even distances to get by road from places to Adelaide to, say, Port Lincoln is 800 kilometres. Adelaide to Mount Gambier is 500 kilometres, 300 kilometres to Port Augusta. And of course, if you're trapped over in Ceduna, you're talking the best part of 1,500 kilometres. So the distances are great, and the decisions to move patients are not only complex, but also extremely expensive. So these are not things to be taken lightly. If I could go to the next slide, please. I've already mentioned that Quentin lives in a fantastically beautiful city of Port Lincoln, which is a long way from Adelaide. Going west, the next serious city is Esperance, and going across the water, which is a relatively short trip, but is of course difficult because it is over water, is Adelaide. So there's not much that Quentin can do except resort to Adelaide if needed. Within Port Lincoln, next slide, please. Within Port Lincoln, however, it does have a very nicely built, reasonably well-equipped hospital. It has scanning facilities, CAT scanners. It has very nice operating theatres. It has, I think, largely, and Quentin, correct me if I'm wrong, but we have mainly a GP anaesthetic workforce. And it has, its theatres are working every day doing elective surgery, but of course it's also called on to deal with the emergencies. And having myself worked in Port Lincoln on a number of occasions as the general surgeon, I hate the football season and I hate BMX bikes because they bring a whole lot of abdominal trauma in young people that you really wish they'd just taken up lawn bowls instead. Nonetheless, we are faced with these sorts of problems, and of course the road trauma is not insignificant. So if I could have the next slide, the sort of case that appears would be typified by this. This is in fact a grey nomad who decided with her husband to head off and take in Australia at a time when she probably should have stayed in the metropolitan area. She's 75 years old. She's had a history of multiple abdominal surgical procedures, which she's diabetic, she's hypertensive. She's presented with this CAT scan showing a small bowel obstruction. She does have relatively normal bloods. She hasn't passed any wind for a couple of days, and it's 10 o'clock in the morning, and Quentin's been asked to see this patient who seems to be reasonably stable. Quentin, what are you going to do with her?
Well, I guess we need to know what her surgical history is, but she's obviously got a small bowel obstruction. I think if she's stable, then we'll start the normal conservative management of nasoenteric tube, IV lines, IVT. If she's well enough, probably not a catheter at this stage, but consider putting in a catheter for management. Give us early in the day. Look, I might even think about giving a gastrographin on that day to see whether that can either help stimulate the resolution or give us some idea of the level of the cutoff. Admitter, so yeah, admit analgesia, antiemetics, drip and suck, and think about giving her a gastrographin follow through and see how she gets on.
So if she fails to resolve over the next 2 or 3 days, but is still got a manageable situation, you'd be comfortable in Port Lincoln to do a laparotomy on her, providing it isn't an abdomen that's completely hostile.
Certainly. You haven't mentioned any significant comorbidities. So she's a little bit overweight from the CT scan, but certainly not obese, and I don't think she'd be over our BMI limit. So as long as our anaesthetists are happy, I think that would be someone we would certainly take to theatre if she's failing conservative management, if she's not settling.
If I could have the next slide, please. By 8 o'clock that night, she's really showing a lot more distension. She's very peritonitic, and you and you really have been probably undersold on her comorbidities, and your anaesthetic colleagues, if I could have the next slide, please. Your anaesthetic colleagues have had a look at her and have decided they don't want to go anywhere near her, and they don't know why you even allowed her to stay more than 24 minutes in the hospital, let alone till 10 o'clock at night when she started to deteriorate. So the decision is made at that moment that the RFDS, next slide please, the RFDS is the solution you will be wanting to employ. Can I ask you, in this situation where you yourself feel happy to go ahead and do the operation, but your anaesthetic colleagues feel that that's not an appropriate case for Port Lincoln, what would be your normal way of arranging that transfer?
Well, certainly first I'd obviously discuss with my anaesthetists whether they think any operation is going to be have a poor outcome for this lady, or whether they think we might be able to operate and keep her intubated while we wait for retrieval. But our first call is always to MedSTAR to sort of let them know about the case, discuss with them. We're usually helped by one of their receptionists who take the details and then discuss it with the on-call consultant, who then is usually put on the line, and we discuss the patient with the MedSTAR consultant and usually come to some sort of consensus or agreement about the urgency of this patient and whether they would be best served by sending out a retrieval team or whether they might be stable enough to go by RFDS.
Well, I think in this case, the decision's been made that they'll be okay for an RFDS. The trouble is, it's at least 4 hours away before a plane can even land in Port Lincoln due to the demand for these sorts of transfers around the state on this particular day. So in that sort of context, would you also be having a conversation with the consultant or the registrar or someone in Adelaide?
Certainly, as soon as we start thinking about transfer, obviously, as well as contacting MedSTAR, we'll be contacting the on-call surgical team. It depends, historically, I've had good connections with the Queen Elizabeth Hospital, so that's often my first port of call. But I think more and more now we're also relying on the Royal Adelaide to help with our patients. So have a chat with the on-call fellow or the on-call consultant, who are really always happy to accept the patient. But then it also comes down to ICU bed status if they think this patient's going to require ICU. And that often still does require a bit of calling around just to either both from the receiving hospital and from us to just make sure that the ICU not only have a bed, but they have nurses to staff that bed and are able to accept the patient if needed.
So you find, I mean, who are you actually calling usually? The registrar, the fellow, or are you actually talking to the consultant?
If it's myself, I call the fellow or the consultant.
Okay, and are you? I mean, why would you select the fellow over the consultant?
I think just availability. They're often a little bit easier to get hold of initially. They're going to be involved with the patient, I think, face to face a little bit more than consultant, and they need to know the details. I certainly, I know, and I'll also often call the consultants afterwards once the transfer is arranged, just to make sure they're in the loop as well.
Mary, can I ask you, do you think you should have a conversation with Quentin at this stage, or are you going to just pick up the pieces when they arrive?
Thanks, Guy. Look, it depends. Obviously, Quentin has done a good assessment and he's relatively happy. The patient's stable. They're considering an RFDS transfer. What would usually happen is we might get a call from the surgical, and it may not be the fellow, it's probably more likely a registrar or something, to say that this patient would be coming, but presumably they'll come through ED and we'll all sort of see what evolves. So with this particular scenario, not usually. However, very happy to have that conversation if the doctor from the referring doctor wanted to have that conversation. But I assume in this particular scenario, Quentin's reasonably happy that the patient is stable. Their hemodynamic is stable. Yeah, they're sick, but they want to get them out quickly. They want to get source control, but they're still stable. So probably in this context, no, we wouldn't normally. No.
Okay, so Darren, your fellow who was actually not on that particular day, it was some relieving fellow. He's accepted this patient. Did you want to know this patient's coming, or are you just happy to let him sort it out when it gets here?
Oh no, absolutely. I want to know what's going on, even about the most minor of cases that's under my care. But I think it's true when what Quentin says. The fellow is usually on site and can get a lot of the logistics organised much better than one of the consultants can necessarily if we're not on site at the time. But we definitely need to be involved as consultants, and in terms of making plans for what we're going to do. Because I mean, if it's a complex case that we're going to need to potentially take to theatre, whether it might be a retrieval or someone who's more unwell, we need to plan around that. And also just so that we're, obviously we're, finally the responsible party to be involved in decision making, and also to talk, obviously it often does go between the rural surgeon, whether it's Quentin or someone else in another hospital such as Mount Gambier or elsewhere. They often talk to the fellow first, but then we have a discussion, often consultant to consultant afterwards, just to fine tune the details and get as much information as we need.
Simon, this case, as I've painted it to you, is in fact a situation where the anaesthetists in Port Lincoln have decided they're not comfortable to put this patient through an anaesthetic for what may be a prolonged operation. Of course, no one has any clear idea. Are you prepared to sort of help them do the operation in Port Lincoln in terms of providing sort of support and counsel, or would you be more happy just to get the patient moved?
Look, if any GP anaesthetist gives me a call and says I've got a problem, I'm more than happy to take the call, whether I'm on call or not, and have a conversation about what's bothering them. Having said that, if they've already expressed the opinion that they're very uncomfortable to take this patient to the operating theatre. I'm not going to stand in their way. The patient sounds like a relatively standard presentation at one of our public hospitals in the city, and I'm not 100% sure of what the regional centre, be it Port Lincoln or somewhere else, is capable of back of house, not just in the operating theatre. So their concerns may be in the operating theatre, maybe what's going to happen to the patient as soon as they get off the table, and you know, their concerns are very, very relevant to the conversation.
Quentin, I get the feeling you don't think your intensive care in Port Lincoln is going to be able to provide the support you want for this patient.
Well, no, if they're deteriorating, becoming unwell, and the anaesthetists aren't happy to anaesthetise it, then we're all going to be concerned about their post-op care. Look, we don't have a high dependency unit. We have a couple of monitored beds, but we can look after art lines and central lines for very short periods, but they're not happy to look after those on the ward. So essentially, if someone's requiring monitoring, arterial and venous monitoring, then they need to be retrieved. So that really, if there's concerns about needing high HDU level care post-op, then that patient would need to go to Adelaide or
I think
centre.
Yeah, it'd probably be fair to say that that applies to nearly all of our South Australian rural centres, with the exception of perhaps Mount Gambier, which again has monitored beds, but certainly doesn't have the ability to keep them on a respirator of some sort or ventilated.
Okay. Interest, if I might interject.
Yes, of course.
Just in Port Lincoln, Quentin, what is the capacity for keeping a patient ventilated post-operatively until the retrieval team arrives, in the case where you do take them to theatre but they still can't be managed, you know, in the local hospital? I mean, they just sit in recovery, and they've got they can stay on the anaesthetic machine, or how does it work?
Yeah, well, often they'll leave them on the anaesthetic machine. They can usually transfer them to our procedure room, which is our scope room, and keep them there while we wait, or can do it in theatre depending on what's best at the time. They can certainly ventilate them, and patients have been ventilated for 24 hours in certain circumstances waiting for retrieval. They can provide inotrope support. Usually, it depends on the anaesthetist. Some are quite comfortable doing that. Others do rely on support from either MedSTAR consultant or other anaesthetic support. But certainly they can, I guess we have a limited number of anaesthetists as well. So when things start going for more than 6-8 hours, then we do need to be wary of our anaesthetists. There's only one anaesthetist on call at any one time, so they do need to sort of change over as well. But no, it is possible to keep those patients ventilated with inotropic support and monitor with art lines and central lines if needed be, while we wait for retrieval, and that usually is in fairly heavy consultation with MedSTAR or ICU.
Sorry, Quentin, and following on that conversation or that question, presumably the anaesthetist, the GP anaesthetist, has to stay and look after the patient. Would you have enough nurses to look after that patient for the 6 to 8 hours or whatever time it might take for the next step for MedSTAR to come? Or
the anaesthetist has to stay, and the nurses, that is problematic as well, because our theatre nurses are the ones who on-call theatre nurses do all the retrievals, whether it's a surgical patient or a medical patient. So fatigue for them is a major issue.
For sure, and the ability then to run the theatre the next day or whatever, because already now you're going to be down nursing staff, you're going to be down one of your anaesthetists who also probably has an obligation, their GP, so they've got to run their practice or look after their other patients. So obviously, it's complicated. Thanks.
That is all true.
Yeah. Let's just go to the next slide, because the RFDS the decision was made to transfer the patient. The RFDS were going to turn up, but then at 2 o'clock in the morning, as it always happens, suddenly the patient becomes peritonitic. They have another scan. There's free gas, there's fluid, and the whole situation has deteriorated dramatically, and the patient is in severe trouble. They're needing to be supported with inotropes, The decision is that, well, the decision is to get MedSTAR. If I could have the next slide, please. And of course, MedSTAR is a fantastic service. Andrew, can I ask you, what's MedSTAR going to do in this situation? You're now going to get a call. The patient's gone off dramatically. What's going to happen?
Thanks, Guy. Well, I'll take you back a couple of steps actually, because unknown to a lot of people, all the calls for inter-hospital transfers as well as retrievals come through MedSTAR. So the state government through SA Health pay the RFDS for use of those planes for those lower acuity transfers, all of which get triaged and a history taken by a MedSTAR nurse in our EOC, which is our Emergency Operations Centre on Greenhill Road. So we already know about this case. This is not the RFDS don't own the clinical governance on the case. They're providing the resources, and it's whether we need to up triage or down triage. I think the good thing from Ralph's point of view is, and most regional centres, we have a poster up in their resuscitation room alerting clinicians, especially because there's a lot of locums coming through, of the conditions that we'd like them to call us about and call early from a planning perspective. Now, whilst there might be some horrendous stories about 6, 8, 10-hour waits, that certainly is not the norm. And again, with planning, we can use assets. We have 2 adult teams 24 hours a day and 2 kids teams 24 hours a day. They're vying for the use of 2 helicopters, and 4 RFDS planes that are split between inter-hospital transfer and retrieval, 4 during the day and 3 at night. So to get to Port Lincoln's not hard. It's just whether we've got the resources and whether the weather's going to be in our favour. The beautiful thing about this kind of case is, instead of multiple people calling each other, you can call into MedSTAR and we can hook everyone up. We can bring Mary in, we can bring Ralph in, we can have the GP, we can have the medical retrieval consultant who is of an intensive care, anaesthesia, emergency medicine or ACRM background and have been doing the job for quite a while, to get a clear picture of what's going on. We also have telemedicine, so we can get that picture of turning it on, because a lot of times the patient may be undersold or oversold, and actually having the clear telemed to see what they look like can help, and certainly is easier for us to make decisions. During the day, sorry.
Sorry, to ask you, Andrew, just before you go on, and please, I'm not trying to stop you, but how often does that actually happen? I mean, my experience is that I have never actually had that occur. I mean, is that because I didn't know about it, or because you guys aren't bringing it to my attention?
Well, I would hope that in our evolution, we've been going for 15 years now, I hope that the maturity of the system, it just depends on a case-by-case basis. If this is a straightforward case that is critically unwell, needs to be transferred in a time-urgent fashion, there's minimal conversation, and then we'll catch Mary up afterwards. Because if we don't need Mary's input from an ongoing management perspective, or Simon's input from an ongoing management perspective, we will dispense the team, get them going as quickly as possible, give the advice as needed. And a lot of times, especially for places like Port Lincoln, they're pretty sophisticated. So is Mount Gambier. They're not going to need a whole heck of a lot of advice. The single doctor town might, if we go out, further, Sejuna. So we'll give advice as required, but the whole thing's about time. So whilst I've got the story from Ralph pretty quickly, in the background, even without Ralph knowing, I've said dispatch the team in a plane with blood and get them going, because I know that to fly there is going to be 45 minutes, and we know they have to land at the airport. We've got an ambulance at the airport so they can self-drive themselves in. That's another 15, 20 minutes. So we know the times that are involved with all of this as well. The beautiful thing about those multi-party teleconferences is that I can give Mary an update as to what's happened with the patient, what time they're coming, are they intubated now, do they have lines in, are we running infusions, and we also can get the surgeons involved as well. So that they know what's going on. So it's an information sharing, and what we try to do is not have sidebar conversations, because the beauty about the MedSTAR line is everything that we initiate or comes into us is recorded. So from an audit and a governance perspective, it's great to actually review those at a later stage.
Yep. One of the things I always find when MedSTAR gets involved is they just ask me to put more and more lines into people. Is there ever a moment when you've got enough lines in someone?
Oh, Guy, I mean, again, you know, we're talking about the luxury of living in a hospital, and lines don't jump out in a hospital. When you move a patient from a hospital onto one or two barouches, into one or two ambulances, in or out of a helicopter, in or out of an RFDS plane, 2 or 3 times to get to the Royal Adelaide, by the time that we hand them over, and I'm not saying this is all of our doing, but those transitions in movement can dislodge. And I think the other thing that a lot of those consultants are trying to do is they're trying to get the most insurance policy that they possibly can. You know, if we know that we're going to be an hour and 50 minutes before we walk in the door, what are some of the sensible things that we could suggest? And I would hope that they're suggestions rather than orders, because we also have to play to the strengths of the people that are referring patients to us. If I ask a GP in Wallaroo to put a central line in and they haven't done it for 10 years, that would be wrong. What we want to do, our kind of mantra is, and we're not just getting this is off of EMST, but 2 secured lines is always a good thing. And if any patient's on inotropes, we'd like to have an arterial line. And by virtue of that stage of the game, we'd love to have a urinary catheter. All of these suggestions that we make, if they're in the skill set of the people that are referring the patient, will decrease the time that we're on the ground. Now, I can tell you from a critical intervention point of view, if we're coming to extract the patient from Ralph, we know from our historical data that we can be out of that hospital within about 40 to 45 minutes. Okay. And we know that's about the minimum amount of time by the time we'll get a handover, do some critical interventions, and or stabilize. Now, if they're not well, it might take longer, but 45 minutes is about the average. So you say that it's going to take an hour to fly, 20 minutes to drive, 40 minutes to stabilize. We've already lost 2 hours before we're not even on our way back to Adelaide. We know all of these times, and they're very predictable. And it's kind of interesting for those who haven't worked in retrieval or lived outside of Adelaide, is, you know, the Royal Adelaide, you know, the surgical registrar will say, I was expecting them hours ago. And when you walk them through the story of what actually has to happen, the distances we travel, and the different in transfers of platform, it's great if you're going by helicopter. And what Ralph's going to be really happy to know is that our new helicopter contract, which comes in about 18 months, I can fly in a helicopter to Port Lincoln in probably the same or less time that I'm going to fly in a plane. So I can go point to point. Anyway, I can wax on about that for a while. I'll pause there if you want to.
Yeah, well, I have this
Guy,
picture.
it's David Walsh.
Yes.
In the chat, there's questions about what if it was an obstetric emergency or a pediatric case?
Sure. Okay. Well, obstetric emergency, that someone's asking the curly ones. The general team look after the mother, and the kids team will look after a baby. We're not going to look after a mother without the baby out. That's basically a midwife territory, or that's the obstetrician at a rural facility. What we would suggest is, if there's an obstetric emergency, let's transfer that patient in utero to get them to Adelaide if they possibly can, if it's known about. Otherwise, it's working through the perinatal advice line, which is set up through the Women's and Children's Hospital, that has obstetric advice and also neonatal advice to get the best care. We can provide a team to look after the neonatal side of things, or we can provide a team to look after the mother side of things. If it's a pediatric case, we've got a MedSTAR Kids team. MedSTAR Kids have still under the same umbrella, still under the same training. But again, the general side will look after all adults and primary trauma outside of the hospital, whereas the kids team will look after neonates and pediatric cases that go to a hospital. I can go delve further, but that's David, does that answer the people enough?
No, that's good. There was a question that just came through, which I guess is worth just asking, and that is that what is going to happen, and Quentin, maybe you're the one to answer this, what are you going to do about the anaesthetist? You only got one anaesthetist, he's trying to keep this patient alive, and another emergency rolls into your ED that needs an anaesthetic support. How do you actually manage that in the real situation?
Well, we have 4 anaesthetists in town, all GP anaesthetists. There is a second on call, so the second on call will be called. And then, anyone who's going to be, who is still in town and available will come in, whether they're on call or not, in an emergency like that. Even with a critically unwell patient, often the anaesthetist will call one of their colleagues to come in. So often with the critically unwell patient, we might have 2 of our anaesthetists in there, just giving each other support and working with the patient as well. So just because there's only one anaesthetist on call, they can usually find someone else to provide assistance somewhere.
Well, certainly my experience has been there seems to be a lot of hands when it really does get difficult, but it's always a worry that if someone's going to be on holidays, someone's not going to be contactable, and then suddenly your numbers are very much down to the bare minimum.
And Guy, we're very, very aware of that. And I think if you talk about many hands, interesting case from a few years ago, shark bite at Port Lincoln, patient basically lost a leg and exsanguinated. The system came together, the different players and the ability to coordinate from Adelaide, have a helicopter go to Port Lincoln. And so the whole chain from the volunteer ambulance to the locum doctor to the surgeons to the aeromedical team to the receiving team back in the Royal Adelaide to ICU, everyone kept being kept up with what's happening and a clear central clinical coordination so that mixed messages aren't being sent. We can't solve all the staffing problems, but I can tell you when problems happen, people do come out of the woodwork. We've utilised the police to bring blood from different towns. We've utilised the We've utilised the police, to bring doctors from other towns, Cleve, Cowell, Kimber, Woodner, that whole triangle of being able to move people around. And that logistical oversight that the medical retrieval consultant has is useful to take the cognitive burden off of some of the rural centres that are dealing with some really bad stuff.
Yeah, I'm a little bit concerned when I look at this picture we have on the screen at the moment. It seems like the 2 men in blue are doing absolutely nothing. Are you heavily overstaffed, or is that just an unfortunate photograph?
So that's training at the base, and that's is a outdoor intubation, showing them how difficult it is in the daylight to what a normally simple tube would be. But we do our induction training so that doctors, nurses and paramedics can learn how to work outside of a hospital environment. We do this twice a year on induction. So that's down at West Beach at our purpose-built base. But I wish we had heaps of staff. We're always looking for good people to come work with us.
I guess one of the questions that's always filled me with horror is within the aeroplane, you touched on this with your response to my comment about lines. You really don't want to have to do too much in the aeroplane, do you? You want the trip to be boring.
You do. So, and again, I've touched on the question that was asked about the compression effects. We can't, the helicopter flies at about 5,000 or 6,000 feet. So those pressure effects for what we're dealing with, and I won't say negligible, but we're aware of them, whereas we can pressurize the RFDS plane. So we can fly at 17,000 feet and have a ground level pressure in the aircraft. We're a bit slower and a bit bumpier. The aircraft itself is tight on space, and you're right, you want the line secured, you want all the spaghetti sorted out, i.e. the tubes and the lines all knowing where they are. You want enough drugs drawn up, you want your headlights so that you can actually see these things. You want to be able to be on headset to talk to your teammate, so that you're actually able to share the information and see the monitor in flight. You also want to prepare for the what ifs, and the what ifs are, if this patient looks poor before we leave, they need to be intubated. The inotropes need to be drawn up. The lines need to be in and secure, and the art line needs to be working. You don't want to be trying to put an art line in by our ultrasound in the back of the aircraft, but you do want to have some contingencies. Are they going to blow a pneumothorax, and do you need a scalpel to actually do a finger thoracostomy in flight? Are you going to lose the tube? Hopefully not. It's secured and tied, and you've checked it before you've gone, but you've got a bag valve mask in case you have a ventilator failure. So it's all the contingencies that you run through that mental rehearsal, so that you are prepared. If something does go wrong, you can deal with it. And having a spare syringe of adrenaline in your top pocket always helps.
Yeah, Quentin, we've painted the scenario here of this patient because of your anaesthetic team feeling a little uncomfortable to go ahead. Then she's crashed and is really very unwell. Would you consider actually now trying to reverse the decision and do the laparotomy to get the situation stabilized before transfer? Or do you really think that, given the way it's developed, transfer is the only possible solution?
Well, I guess we need to know what the family and the patient's wishes are as well, whether what sort of they want done. But I think if retrieval is delayed in any way, and I think the patient is not going to survive until the retrieval gets there, or they might not survive retrieval, then we'll again talk to our anaesthetic colleagues and make a decision. They might say, well, she's not going to survive anything if we put her to sleep here anyway. And then I guess then there's a hard decision about whether to palliate this patient. But no, if our anaesthetists were happy that we could anaesthetise the patient safely, even with some risk, and do the laparotomy, try and control or get sepsis under control, wash the patient out, and then keep them intubated while we wait for MedSTAR to get there, then certainly we would revisit that and keep talking about it.
Yeah.
Could I ask a question on that note? Because I think that's a really important point, because Andrew has just described an amazing service. It's top quality. It is. It's just fantastic. But obviously there's weather, there's issues, do we have any data? Quentin, would you have any data? So I think Guy's question is a really good one. So yeah, time is money, isn't it? We need to get source control with the patient. You're cognizant of this. The time is, unraveling before your very eyes. She is deteriorating before your very eyes. So you decide, do we have any data? Maybe David, you might have those data, or Quentin, you might have them, about the patients who get transferred, who have their surgical intervention, they have their laparotomy in town, versus the ones who have the laparotomy, an emergency laparotomy, and they get transferred post the laparotomy. Do you have any data on, outcomes in those two groups of patients?
No. I don't really know. Sorry, Mary.
That's okay. I thought
it'd be an interesting paper to look at, but I think the numbers, Mary, from my experience at MedSTAR, the numbers are fairly low, and I think what Guy was trying to get at is, and we've had this on occasion, that the surgeon has felt very uncomfortable, and we've had situations where they've said no, and we've not been able to go, and you're kind of in this quandary about, well, what is going to happen? And I guess one of the topics, and we didn't go down in the first instance, but is this 75-year-old lady with lots of comorbidities, what are her wishes? What has she decided? Because again, the easiest thing is to pull the trigger and to mobilize the cavalry, to send a $4,000 an hour helicopter or a $2,000 an hour plane and a limited resource of retrieval teams, and then bring them to you in an ICU bed and a resus bay, take them away from their family, their country, all their ties, for them only to die. And we've done an exercise in treating the doctor and being able to flex the system, but have we actually looked after what the patient wants, what the family wants, and the rest of it? And one of the things that we've been doing quite a bit, and we've got several people that have done quite a bit of work. Matt Hooper's one of these that's done quite a bit of palliative care, and I've done a number of cases whereby getting the specialists on board, and I can remember cases with a neurosurgeon, an intensivist, myself, local doctor, and the family in a centre that we're able to get scans and having the conversation, are we going to do something, and coming to a point of agreement that the family and the patient's wishes were not to move. Now that raises a whole lot of different things for Quentin as well, because then are they able or willing or ready to take on that end of life care or that palliative type care approach as well? So that it's a multifaceted thing that needs to be looked at from a discussion, but we're certainly in a better position now to have some of those discussions and hook people up to have it. The last thing you want to do is foist that upon the local GP, and I'm taking it outside of Port Lincoln, because that GP lives in that town and looks after those patients and has to see them every day, and the family don't want to be left guessing, did that GP make the right decision versus was that a shared decision amongst senior consultants that were aiding that GP and the family.
Darren, this sort of decision about transfer, you get called about this case. You are being, Quentin has assessed it. Imagine he's assessed this as being almost certainly unlikely to be salvageable. She's crashed so badly and all the rest of it. Well, perhaps I could ask you, how do you manage that? Do you still say, no, look, send her over and we'll give her the only chance she's got? Or are you comfortable providing support for the decision not to transfer a patient you have never seen?
Oh, absolutely. I mean, I think if Quentin's assessed the patient or one of the other local doctors, wherever they happen to be, I mean, it's a bit less so for your very small country hospital. But yeah, if Quentin's assessed the patient and we've had a discussed with the family, and we think this is futile, it's not in anyone's interest to call the retrieval and get her sent to Adelaide just to die, then I'm very happy to make that decision on the phone. I think the difficulty is in the situation of being the receiving, service, is to say, if Quentin's saying, no, I can't manage her here, I think it's the right thing to do to send her. The family want everything done. She wants everything done. I think it's very difficult, without having seen a patient in person, to be able to say, no, I'm not taking her. And I tell my fellows and my registrars, if they get calls, that we can't do that because we don't understand the local facilities. We don't understand what the local situation is. And, in the end, Quentin or whoever's there has to make that decision, with assistance and with their help as much as necessary. But I think we have to take that on board and accept that patient if that's seen to be the right thing to do. And sometimes in hindsight, we look back at it and say, oh, that didn't work. And it perhaps wasn't the best outcome if nothing goes well. But I think that is just part of the whole process, just the same as the fact that, we've got a fantastic retrieval service and MedSTAR does all the right things, but it still does take the amount of time that it takes to get there and to settle and to retrieve them. And that's assuming that there's a helicopter or a plane that's available right now to go. There is always going to be a delay.
Well, on that, I can also just butt in and say we've just renegotiated our hospital transfer and retrieval plane policy. I've now cut the time down. So I used to have to wait by the policy, by the contract with RFDS, 45 minutes during the day and 60 minutes during the night. I now have a retrieval plane that I can activate and be airborne within 20 minutes. And with the helicopter, if it's available, I'm airborne within 10 minutes. So those things we have made some improvements. And just following up on did we do the right thing or didn't we do the right thing? Each week we run clinical case reviews or clinical development day once a month, where we pull these cases apart, and anyone from SA Health is invited or able to attend, and we try and look at it from a longitudinal, multidisciplinary factor, and including Quentin to get involved, the nurses, the paramedics, so that we can actually look at from the point of injury or illness through to discharge from the hospital. How can we improve on it? Or how can we change it?
Andrew,
could I be a bit controversial and follow up?
No, Mary, go.
Which I really love what you said, Darren. That certainly resonates with me about that conversation. But it must be, as you said, obviously, we can't leave Quentin or his colleagues, out and, we can't leave them unsupported or feeling unsupported. But do you ever get a sense, because I'm going to say I do, that there are some of your surgical colleagues who really are desperately uncomfortable with making the call that you have just described? not about, on discomfort at the referring end, but more their own discomfort about not being able to make a decision, that kind of decision about a patient, unless they actually set eyes on the patient. And I suppose in today's world, with, as Andrew said, really sophisticated telemedicine, sophisticated ability to see scans, see bloods, see everything, I'd just be interested, because it's something that's been said to me where I've said, why are we taking this 97-year-old with a lot of deadness going on from my perspective? And it has been said to me, I'm not happy to do that. Maybe it's medical legal. Anyway, just your thoughts, maybe.
Yeah, I'm sure that is the case. That some people may feel uncomfortable with refusing a transfer based on that.
Yeah.
I think, and even like you say, a 97-year-old, that's probably a bit of an extreme one, but someone who's
Happens.
You're probably right. I'm sure you've seen it. But you can have a healthy 90-year-old who's got a good quality of life. And I mean, if I ran through that with Quentin, I said, look, are you really sure? I mean, this is a high risk thing. Do you really think it's the right thing to do? And if you come out of it and Quentin is the person on site and he says, yes, this is what we want to do, then I would go with that, and I wouldn't push back any further. I mean, I would definitely discuss the pros and cons and run through that whole, is palliation the right thing to do? But I think in the end, we do have to, take our colleagues.
Of course. But it also emphasizes hugely, doesn't it, that importance of that direct communication between a senior person at the receiving end and the person who's actually trying to deal with the situation at the referring end.
Absolutely.
Sorry, Guy,
absolutely.
Sorry.
No, I agree. Look, certainly when you've got that patient who's terribly unwell and they might be elderly, and that the outcome from an operation, even if it goes well, is not going to be great. They may well be losing their independence, or it's unlikely that they're going to get home afterwards, or there's a high risk of them not surviving the operation at all. You might say, look, I don't think the operation is the right thing. I think the best aim is to make you comfortable. The family are sometimes comfortable with that, sometimes not. But I think if the person from the rural area is calling, I think from Darren's point of view and the others, it's very hard to say no. And it's the same for me. Once someone calls me asking to send a patient to me, whether that's from Ceduna, Woodner, Cleve, anywhere like that, I think your first response has got to be, yes, I'm going to take that patient, and you've got to have a very, very good reason to say no, don't send the patient to me.
Look, absolutely, but I suppose it's neither all or it's not all or nothing. There's obviously that bit in between, isn't there? And I'm really interested to hear your comments about what we would call the burden of treatment, the burden of care, because you're dead right. Like, you can send the patient to town, they can have an operation, but if the elderly comorbid patient, like this woman, we don't know, she's probably got the diabetes, the peripheral, she could have a whole load of comorbidities, which Guy hasn't told us about. And so she survives the operation, but she ends up in ICU and multi-organ failure with, dialysis and ventilation and da-di-da, and then doesn't end up being back in the caravan, being the grey nomad that Guy has, that she was when she started off. And I think that's such an important part of these conversations, isn't it? It's the burden. We can do things, but there is a burden attached to, and then we need to, I suppose, that communication with the families, that they know what the possible other outcomes might be. Anyway.
Yeah. And I think as well, just the difficulty with this particular situation is that, yes, the decision's been made. Yes, she needs an operation. We can fix it. We're going to plan to send her, and then things change and she deteriorates, and the family and she and her husband are under the understanding, yes, she can survive an operation. She's going to Adelaide. This is great. And it's sort of set in train already. And it'd be very hard then to back off and say, oh, no, it's too late. We're going to change it. She's going to die.
Yeah.
And
that's 100%. It's really
and that's one of the I think that's one of the benefits of the retrieval service in being that independent arbiter, that you can have that try and have that time out. It doesn't always work. But if you haven't got that emotional buy-in and you're looking at it from an objective perspective, it just does give a different set of eyes and a different opinion on it. It may not always be the right one, but I think it's good to voice those. And again, I'm right with it. Stopping that train is very, very difficult once everyone's on board.
Yeah. Moving on to the next slide, if we could, I just wanted to give you a picture of where Mary lives. And this is the world where everything that you want exists. And it's not surprising that the transfers often want to head in this direction. And the next slide, please. And of course, you have a hospital that has every specialty represented, and everything's there. I well remember having a patient with a head injury in Port Augusta, and I rang the registrar because that's the only person that answered from the neurosurgical team. And I did ring the neurosurgical registrar, and he wanted to know what the vascular surgeon in Port Augusta thought about the case, which I pointed out that actually I was the vascular surgeon, the orthopod and everything else. They had, often, unfortunately, our junior staff have no idea what is actually available in these towns which we're servicing. So the next slide, and we're coming to the end of this evening. I guess that the point that's been made, and I know Andrew has just flashed it up on the screen, the whole thing is about this communication. I guess what's interesting to know is that there's a very sophisticated communication network that can be put in if that's what you need. And I have to say on occasions that would be very helpful. But we all have phones, we all have Teams and Zoom and whatever else. You can actually have a reasonably grown-up conversation with a grown-up if you wish. And I suspect that this is sometimes, in retrospect, and I think David could attest to this, the breakdown has often been communication, and that is a serious problem. So I wonder if I could just go to the next slide, and that is the take-home messages I think we're trying to get out of tonight is, first of all, it's useful if you do understand the regional limitations, and some people on this line have an absolutely clear picture of it, but most of my registrars have no idea. The second point is that we need to communicate with all involved. Next slide. The consultants, the ICU, the MedSTAR, the anaesthetic consultant. Now, you may not need all of those for every transfer, but I guess what we're hearing from the panel is they are available and they're not going to say that's unnecessary. And I certainly think in a case like we've tried to outline tonight, all of those could have been valuable as the thing deteriorated. And I guess the other point, and this is, I think, one of the big challenges we have, and David is certainly with his assessment of deaths with transfers, it doesn't make a lot of sense to transfer for futile treatment. The patient often is dislodged from their family. The family can't be there in their last hours, and the cost has been substantial. And I thought it was interesting, Andrew, giving those figures. My understanding is a transfer, even with RFDS, is about $10,000 from Port Lincoln to Adelaide. It's not cheap. And if you send them back the same way, that's the same money. And while I don't think it's about the money, you don't want to be wasting it either, because I don't know if you've noticed, but our health system is not exactly overfunded at the moment. So that, if I just put up the last slide, I just put this up because we're about to produce a booklet on deaths with transfers, and we've got about 16 cases which bring out a whole lot of, they're all based on real cases, of course, and really just to highlight the fact that there are a lot of things that can go wrong in these transfers. And this booklet will be going out to all members of the Royal Australasian College of Surgeons. But if anyone else who's on this line who's not a member wants it, just email in and we'll be delighted to send you, an electronic copy of this. It's harrowing reading, but it's also extremely valuable vignettes of the problems that those of us in this space seem to face all the time. So look, we have reached the end of our time. Are there any closing comments from any of the panel? Excellent.
Just one comment.
I knew that was coming.
As always. I think one of the things that I sort of have to deal with all my professional life, and I think we as doctors do need to be able to, is at some level deal with, we do live it with uncertainty. That, it just goes back to your thing. Not every patient needs every intervention just because we can, but we will never be 100% certain. We will make decisions about patients, and had we done the other, they would have done better. But we do have to live with that uncertainty, is all. Thank you.
On that somber note, I'd like to very much thank Andrew, Simon, Quentin, Darren, and oh God, I've forgotten one of you.
Mary.
Mary. Oh God, how can I forget Mary? And Mary for really being a fantastic panel. Thank you for being part of this, and thank you for being prepared to field things that I didn't over prepare you for, because I wanted it to be sort of a genuine response to what is absolutely genuine problems. So David, thank you for organising this, and I can now ask you all to go home and enjoy your meal, and hope you don't get a call from Quentin. See you later. Thanks,
guys.